Welcome to today's webinar being held by the BAPM. My name is Dr. Wendy Tyler and I am the chair of the current working group for the consultant working patterns. The aim of the webinar today is to share with you the results of the survey, which many of you will have contributed to in the spring of 2022. So thank you very much for doing so, and also to generate a discussion towards after the presentations that would help us inform our recommendations reports, which will be written in 2023. So this survey and the results of this are supporting one of BAPM's 4 strategic aims from the BAPM strategy published in 2021, and that is to provide support and advocacy for perinatal professionals. The remainder of the webinar will be split into 5 key areas. I'm going to go through briefly with you the demographics of the survey, and then Dr. Vimal Vasu from the South of England will be presenting the answers for job planning. And for on-call frequency, flexibility and working patterns, we have a dual presentation, a recorded presentation from Dr. Ajit Mahavir and a live presentation from Dr. Sajid Needungardi, both consultants from Manchester. And then Anna, Derbyshire and SG7 from the West Midlands will be presenting the work that she and Helen have been doing with the questions on wellbeing, challenges and future personal plans. And Dr. Helen McAteer, our recent outgoing president of the BAPM and consultant in Scotland, will be running the questions and answer session at the end. So moving on to demographic data, we had 239 neonatal units respond, neonatal unit consultants respond to the BAPM survey. This is comparable to the number of neonatal unit consultants that responded to the RCPCH census in 2022. They had 210 consultants. The RCPCH census said that they only had a 20% response rate overall for all paediatricians, both consultants and associate specialists. It's not possible for us to compare our BAPM survey results currently with demographic denominator data. This is because the exact number of consultants that contribute to neonatal care within the UK and Ireland are actually currently not determined, and we're working to determine this with the Royal College of Paediatrics and Child Health, and also being supported from the Neonatal Network, so we're seeking to source this information. The age of the respondents from our survey of 239 are as shown. 60% of those are less than 50 years or less, and there is an equal distribution of those respondents who were 55 years of age or over, or 40 years and under. And again, this is comparable to the RCPCH census data, which is given here, where the light blue line is the age distribution of all paediatric consultants. The majority of our respondents were female, again consistent with the RCPCH census for wider paediatric consultant and associate specialists. Also similar was the results of our ethnic group questions. So all respondents answered this group, and the vast majority were from the white, English, Welsh, Scottish, Northern Ireland, Northern Irish and British ethnic group, with the second largest group being Asian, British and Indian, and this is the same as for the RCPCH census. We wanted to understand a bit more where our respondents were from, and this chart, the width of the bar relates to the largest number of respondents from each of the neonatal networks. So as you can see, as usual, London, being a very large neonatal network, actually has the largest number of respondents. So we wanted to understand a bit more about the percentage of respondents from each neonatal network, but because we don't have the denominator data available to us yet, we cannot present it in that manner. We have tried, however, to size the neonatal networks, and we've done this using Embrace UK and CSO data given in the blue bar chart for live births from 2020 as a proxy measure. And if you look at our ordered response rate in the green bar chart, you can see that the highest response rate is indeed from London, which is the largest birth rate, live births 2020 population, but the West Midlands, Kent, Surrey and Sussex and Scotland had a high response rate compared to their birth population. The majority of our respondents were worked in intensive care units, so NICUs, where there was combined medical and surgical care. Very few responded from the special care neonatal units. This is in contrast So the GIRFT unit designation distribution that was described in the 2020 report using 2019 data, which shows that over 20% of our units are special care units and more than 40% are local neonatal units. So we are aware that the survey has an underrepresentation from special care units and local neonatal units. In response to national maternity investigations over recent years, we specifically asked whether within a job plan there was formal rotation to another neonatal unit of a different designation to their primary job. Vast majority of people responded to this, and of those, most of them do not have any arrangement in their job plan. Those that do, the majority rotated from a neonatal intensive care unit to either a special care unit or a local neonatal unit, with very few colleagues responding to rotating from local neonatal units or special care units to neonatal intensive care units. 15 out of those 36 that stated that they did have a formal arrangement, and another 24 respondents kindly shared some comments about the detail of their rotation or their linked sites. And these can be seen here in 5 main themes. The majority are at work on 2 linked sites because their trust has combined neonatal units. So they have a neonatal, for example, that has a NICU and a SCBU. There were a few respondents that described their rotations from local neonatal units to neonatal intensive care unit pattern. And these were given as 28 days a year or 1 to 2 weeks annually. Other colleagues cover transport and neonatal surgical cover. Others shared plans in development, and there was a particular comment that ward-round attendance alone for colleagues in local neonatal units rotating to neonatal intensive care units is unhelpful, and the acute experience with stabilisation would be preferable. So trying to understand a bit more about the respondent population, we asked about their first year of appointment as a substantive UK consultant, and everybody answered this question. The value for 2022 is low because the survey went out in the spring of 2022, so it was a part year. I can tell you that almost 50% of our consultant colleagues who responded were appointed within the last 10 to 11 years. We also asked that had they performed a locum consultant appointment prior to their UK substantive consultant appointments, and 91 colleagues had. That's 38% of the total survey, and the vast majority of these had performed that locum consultant appointment within 2 years of their substantive UK post. Interestingly, just over a third of respondents were not on the GMC specialist register for neonatal medicine. And this is interesting because the vast majority of our respondents worked in the neonatal intensive care unit setting. So in more detail, we had overall 62% say that they did have neonatal specialist registration. In the light blue box, that represents the NICUs with surgery and medicine. And 90% of colleagues explained that they were on a specialist registrar for neonatal medicine, and this dropped to just 2/3 in the medical NICUs. But interestingly, more than a fifth of the consultants that responded of the local neonatal units are also on the specialist register for neonatal medicine, and 1 colleague in the special care unit. So if we look in a little bit more detail, if we take the combined NICU, surgery and medical, there were 10 colleagues who explained that they did not have specialist registration, and they were appointed over a 20-year period, including this year. They were distributed throughout the UK, and I've given examples there. There were 3 colleagues from London and 3 from Scotland. For the medical NICUs, there were 22 respondents who said that they were not on the specialist register, and they were appointed over a 25-year period, and again varied in ODNs, with 4 in the West Midlands and 4 in Northern Ireland. And lastly, just to mention that the 14 colleagues in local neonatal units who are on the specialist register for neonatal medicine were appointed over the last 31 years, including some of those before the establishment of neonatal networks. Thank you very much. I'm going to hand over to Dr. Vimal Vasu.
Thank you, Wendy. Good afternoon, everyone. Just bear with me while I share my slides. Hopefully you can see my slides. So my name is Vimal Vasu, and The following slides relate to how our survey respondents answered questions about job plans. I'm just going to put this on full screen. So for programmed activities, our data that you can see here on the slide are broadly comparable to those obtained from the RCPCH workforce census that was published in October 2022. So the median number of total PAs per week was 10, and 50% of our respondents, which represents the interquartile range, worked between 10 and 11.5 PAs. So in the RCPCH census, 66.1% of neonatologists work between 10 and 12 PAs. And as you can see here, the median number of SPAs, supporting professional activities, was 2, which again was comparable to that of the RCPCH census, which was 1.8, but lower than the recommended figure of 2.5. Here are data on neonatal direct clinical care by unit designation. And as one might reasonably predict, the number of neonatal DCC per week increases as you go from level 1 SKUs through to level 3 neonatal units. What was of interest was the observation of marked variation in neonatal DCCs, which was evident for consultants working at level 2 neonatal units. We don't know why this is, but presumably it reflects differing sizes of level 2 neonatal units and the fact that some level 2 neonatal units will indeed have separate rotas. We were interested in understanding what had happened to neonatal consultant SPA time over the years, and we looked at this specifically by year of appointment to the consultant grade. And as you can see here, consultant SPA time has remained at or around 2 PA over the period going back all the way to the mid-1980s. And so that was interesting in that there hasn't been a significant erosion in SPA time from our data. Around 2/3 of respondents, and as Wendy has said, the majority of those are from level 3 neonatal units, had additional programmed activities within their job plans. And as is illustrated on the slide, these included a multitude of differing clinical and non-clinical roles, roles related to hospitals, but also to networks and to education. And one of the things that's interesting here is the huge level of variation in these additional programmed activity roles and whether or not there may be work that can be done to try and standardize, particularly in terms of time allocation, a number of these additional programmed activity roles that 2/3 of our colleagues are involved in. We also looked at the numbers of individual consultants contributing both to the neonatal service and to on-call service, and the data are illustrated as median and interquartile range for both of these, the neonatal service and on-call neonatal service. As one would expect, the highest level of consultants, both for the neonatal service and for on-calls, is in level 3 surgical neonatal units. There is a slight anomaly in the data in the sense that at level 1 units, the observation of higher numbers than at level 2 units probably, one, reflects the small number of respondents, but two, also reflects the usual practice that general paediatricians would cross cover between general paediatrics and level 1 neonatal units, and that's why the numbers are likely to be higher. We also looked at cover for other clinical areas whilst both on call, and the data for that are presented here. So for example, as a neonatal consultant, when on call, do you cover general paediatrics or another neonatal service? And we also looked at the same question but slightly differently in terms of asking the same question, except asking it not when the clinician was on call, but during their usual working week. And here are the data for other cover for clinical areas when on for the neonatal unit. And as you can see, there's an inverse relationship between the proportion of clinicians with additional commitments and the level of neonatal unit. So those on level 3 neonatal units tend to do that the least often. However, a significant proportion of level 3 and level 2 neonatal units did have to cover other clinical areas whilst on call. And our initial view on this was it may be reasonable as long as it doesn't take the attending clinician away from the shop floor and therefore not able to attend to an emergency. Here are the data, same question, except whether or not you covered other services during your usual working pattern, during your usual working week. And the same pattern is evidence. So again, a number of level 3 and a number of level 2 consultants do have additional commitments. And again, this seems reasonable as long as it's not taking clinicians off site. To do away with this completely would perhaps mean that from a productivity point of view, things might be more difficult. And my final slide relates to allocated time in job plans for perinatal mortality reviews. Over the last few years, it's been an increasing recommendation that there are external reviewers for PMRT and that we are all reasonably involved in these mortality reviews. However, it's striking as to the limited amount of time that the respondents to the survey reported for PMRT. So you can see that across level 1, level 2 and level 3 units, between 70 to 80% or so of clinicians do not have allocated time for PMRT. Where they do have time, which is in the minority, it's predominantly recorded as SPA time. And we felt that this observation was important, partly because to do PMRT properly, it will require time, so that it's not a box ticking exercise. And we also felt that rather than being SPA, it was a bona fide clinical meeting. So that's my final slide. I look forward to the discussion at the end, and I'm going to hand you over.
Yeah, so me and Ajit were meant to be doing a dual act, so I'll follow on for probably Ajit's slides would come up in a second, but I'll just go through the questions that I was planning to cover in my slides. So the first one that we were doing was whether on an average, would you expect to be contacted between the hours of 11 p.m. and 7 a.m.? Now, of these 166 responders, majority of those said that they spent around more than 50% of the time. So that was 60% of the group, whereas around 41% said that they spent less than 50% of the time being contacted. And of those who were in the more than 50% group, they were either in the hybrid as a tier 3, or they were purely resident. Now, within that group, when you break them down, 50% were from ICU, which was including both the neonatal intensive care units and those with medical and surgical. And 25% were from the level 3s, which were medical and the LNUs. Now, the 13% of those who were in the less than 50% of the time group were mainly non-residents for all of their shift. And the LNUs comprised of 1/3 of them, and 8% were by the special care units. The next question that was asked was about whether, while you're doing the non-resident on-calls, how long do they spend either on telephone or by their presence per night on the neonatal unit. Now, of the 165 responders, majority in all groups were working on a hybrid pattern. hybrid pattern in the sense that they were either resident for part of their non-resident on calls. There was a wide variability, as you can see, amongst the hybrid group, and there were only 10% of all groups who were off-site for the full shift. Now, the previous two slides also sort of ingrains that there has been probably more of a drive towards a hybrid pattern of working from the as part of the consultant-led and consultant-delivered service. The next question was about whether there were additional daytime hours per weekend day between the hours of 7 a.m. and 11 p.m. that the consultant spent on the unit. And of the 166 responders, you can see that the around 55% said that they spent around 1 to 4 hours per weekend day above their contracted resident hours. And there were more, around a quarter of the respondents who said that they spent more than 4 hours. But when you then break them down, you find that 60% of those who spent more than 4 hours were actually from the high intensive neonatal units, which cater to medical and surgeries. Now, 1/3 of the split across the ICUs, level 3s and LNUs were for the first two categories, which were either less than 1 hour or 1 to 4 hours. Now, this again sort of also highlights the importance of the high intensive areas probably spending more time, additional time per weekend day, and hence could contribute to staff burnout, which has to be kept in mind, but also in terms of when job plans are done to consider team job planning, which might then help with leveling up the time spent. The next one was about if there was a weekend or consecutive public holidays while you're on non-resident on-call shift, then is there a formally agreed backup on call? Now, it was uniform across various levels of neonatal units, and 87% of respondents said that they did not have a backup. And again, that could be because of the current hybrid system of working that the respondents were in. The next one asked about the scope for flexibility of the on-call rota and whether they had thought about it as part of their on-call rota. And now and that was either in the frequency or the type of on-calls. Now, of the 171 respondents, 56% said that they would that they did not see any scope for flexibility. 26% said that they did see a flexibility. Now, again, I think what we come across is a wide difference between the various neonatal units, and hence I think those who are having that scope of flexibility, probably the sharing of ideas across all levels would be helpful to look at whether that flexibility could be rolled out in all neonatal units. Now, when the respondents were then asked whether they were willing to share the trust policy, 67% said that they were not willing, whereas a third said that they would. Now, again, it's difficult to ascertain why that was the case and whether there was a policy in place in the first instance. And my final question that as part of the survey, which I was covering on, was the contribution of the LTFT or the less than full-time consultants to the on-call rota. Now, of the 171 respondents, you can see from the graph that there was a wide range of the contribution of the less than full-time consultants to the on-call rota, of which around 20% contributed to the full on-call program, just over a third for the pro rata on-call. And the interesting bit was that the two main highlights were that 20% went on to have full on-call commitments, whereas a quarter of the units did not seem to have any less than full-time consultant on their rota. And that's something that we might have to explore as part of this. But given that the less than full-time training is actually quite popular and is increasing in popularity amongst the pediatric trainees. So now I would hand over to, I don't know, Kate, are we going back to Ajit or am I handing over to Anna?
Let's try Ajit again.
Yeah,
Okay.
let's try them again.
Good afternoon, everyone. My name is Ajit Mahavir, one of the consultants from St. Mary's Hospital in Manchester. And thank you for giving this opportunity and filling up the consultant working pattern survey, which we're able to analyze. I'm going to be talking about the on-call shifts patterns, the frequency and the flexibility from the survey. The first question was looking at the frequency of the weekday on-call. Most of the respondents have responded they do 1 in 6 or less on-calls during the weekdays. And there has been a slight, around 11% of the respondents where they did 1 in 4 or 5 on-calls. Interrogating this data in the survey with the place of work, majority of them seem to be working in a local neonatal unit. And 1% of the respondent where you can see the on-call where they have indicated as doing 1 and 2 on-calls are kind of within the neonatal intensive care unit within England, and a further analysis needs to be done to understand this. The same question was asked about the weekend on-call, and it matches the weekend frequency, weekday frequency, where the consultants are doing 1 in 6 or less weekends. There's a small increase in the weekend frequency, around 4 and 5, so 1 in 4 and 1 in 5 on-calls compared to the weekday frequency. So again, this is mainly seen in a local neonatal unit where they do a little bit less number of weekends compared to their weekday on-calls. So if we were to compare the age and frequency of on-call during the weekends, so on the y-axis you could see the age group which are being divided by 5, and then on the y-axis, x-axis, you can see the number of on-calls that people have indicated as them kind of been doing. Clearly, after the age of 60 and above, we can see the number of weekend on-calls are far less, or 1 in 12 on-calls, compared to a person who's kind of starting their neonatal consultant career at the age of 35 to 40, where they're doing 1 in 6 to 1 in 8 on-calls, weekend on-calls. Now, how does this compare with the College Work Census 2022 report? So we can see here on this right side of the kind of graph, neonatology is the second line, where you can see on the light blue bar, which kind of shows that people are doing less than 1 in 5 on-calls, which means more on-calls during the weekends. And then the dark blue kind of chart or the bar kind of shows people are doing anywhere between 1 in 6 and 1 in 10 on-calls. So again, very much kind of matches with the frequency that we have seen in the BAPM working pattern survey as well. The next question was looking at how would they describe their on-call arrangements, and they were given the 4 options. The 4 options were purely resident, where they spent all their time on the floor for the entire duration. The second one was around being a non-resident, where they would be off-site unless they've been called in. The third option was around hybrid, where they are part of the shift is on-site and then from home. And then the fourth option, taking into account about kind of general pediatrics, transport consultants, where their rotas would include more than one type of on-call. So we can see majority of them during the weekday and weekend have responded as kind of being hybrid on-calls. Compared to the weekday and the weekend, the only kind of difference that we had kind of seen in the hybrid rota, where people described their rota as 57% of them described as hybrid rotas of their on-calls, and on the weekend it was around kind of 67%. So there's a drop in the non-resident type of on-calls on the weekends. The next question was around kind of, what would they describe their on-call as purely resident? So just looking at that part of the kind of survey, there were 10 respondents out of 167 who responded, which would account for 6% as kind of doing purely resident on-calls during all their shifts. So the next slide kind of looks at the weekend on-call shifts and what are the hours that they normally resident between. So the line in the blue, which kind of is the starting time of their resident shifts, and the line in the orange is the time when they kind of finish off their shifts. Clearly, I mean, you can see here, so most of the on-calls kind of start either between 8 and 9 in the morning, with a few of them kind of starting at around kind of 4:30, 5, and then one or two starting around in the late night around 8 o'clock, and them kind of finishing the next day morning. So most of the on-calls, if you look at the duration, they were spending kind of somewhere between 8 and 12 hours, with a small proportion of them kind of doing more than 12 hours when they were on the night shifts. So the next few slides, we will look at the support that the consultants kind of get during their kind of working. So we'd asked a question saying that if they were on-call shift were described as tier 2 or tier 3, because we know some of the places do kind of have consultants working in a tier 2 rota on a set number of days. So we can see 12 out of 167 consultants did take part in the tier 2 rotas, and this was seen in a mixture of the neonatal intensive care environment and a local neonatal unit as well. So we then asked them if their shifts did have a support from a resident tier 1 doctor. The majority of them have said they had support. 5 out of 167 consultants have identified as not having any support from a resident tier 1 doctor. And the same question was asked in regards to a tier 2 doctor, if they had a dedicated resident tier 2 doctor. Again, majority of the people have kind of responded as yes. There's a 5% of people, or kind of 7 of them, who have responded as not having any support from a resident tier 2 doctor. And again, putting that if people were stepping down to be a tier 2 doctor's consultants, then obviously they would not have a tier 2 doctor. So that's something to kind of bear in mind there. Now, if you were to look at standards of how we could kind of talk about support and what kind of medical workforce that we should have on the neonatal units, whether it's a NICU or an LNU or a SCU, we know that we all have kind of the BAPM BAPM requirements or BAPM kind of recommendations that have come about in 2021 and 2018, and also kind of this year. And as part of every trust who are involved with the CNST scheme in the past, or the maternity incentive scheme now kind of running year 4, we need to kind of show that we do kind of are able to kind of meet the expectations of what has been described in the BAPM. So again, tier 1 and tier 2 resident cover is something that's been well described in the BAPM arrangements, BAPM recommendations. So we should be kind of really looking to kind of make sure that our units and our trust are abiding by these recommendations. So on the people who were doing resident on-calls for either part of their shift or for the entire shift, we'd ask them how many hours of sleep did they manage to get during an overnight resident on-call shift. Now, it's clearly around kind of 60% of them it didn't apply, because they were only part of it were on resident, and then they kind of gone home from there. And people who were kind of on the floor, there were around 3% of the consultants who had said they had not had any sleep during their resident on-call shift, compared to the rest of them kind of saying anywhere between 1 and 3 or 4 to 6 hours of kind of sleep during the resident. The next question was kind of looking at how to see kind of the teamwork within the consultants. So do fellow consultants participate in the same resident rota? And almost 68% of them have responded as their fellow consultants working on the same rota, which would again mean there is a hybrid working pattern in kind of place, and that's how we kind of make it kind of meet the demands. The next question was kind of looking or further exploring whether there was a scope to lessen their commitment to doing all resident nights as they progress through the career. 10% have responded as yes, and double the percentage of around 20% have responded as no. They didn't have any commitments as kind of written commitments or any kind of written documents to kind of say how they would progress through their career. But then we also kind of then asked a further question if they were content currently doing kind of resident nights. Clearly, slightly more than half of them were kind of content in doing kind of resident nights as part of their career, and some of them weren't. So again, a bit of work for us to kind of think about what kind of recommendations we come up for kind of future working pattern and looking at what we hear from the rest of the team today. And that's all I had to kind of talk about these kind of slides. And I now hand over to my colleague, Dr. Sajid Nedangadi, who will take us through the rest of the slides around kind of the on-calls, shifts and frequency. Thank you.
Good afternoon, everybody. My name is Anna Derbyshire. I'm a neonatal grid registrar based in the West Midlands. I'm just going to share my screen with you now, and hopefully that has worked for everybody. So we're going to move on just to, this is the last section of the survey, and the questions here were particularly focused around wellbeing, challenges faced by neonatal consultants and future personal plans. The first question that was asked was about access to free parking at the hospital that the consultants work at. And you can see that actually just under 3/4 answered that no, they do not have access to free parking. There was some disparity across the UK as a whole, in that 100% of people who responded from Wales answered yes to this, as well as 71% from Northern Ireland, 65% of Scottish respondents as well. Within England, there was a real mix. All areas had some free parking. The highest proportion of this was seen in the northwest, with 53% of consultants who responded answering yes to that. Just thinking about that a little bit more, we do know that most hospital car parking charges were abolished in Wales in 2008 and Scotland in 2009. However, in England and Northern Ireland, the only government mandated exceptions are staff working night shifts, and that's actually quite a recent change in legislation. But it's worth noting that that's only after 7:30 and for shifts that finish before 8 o'clock, which actually will exclude a lot of medical staff. There was some statistics to show that staff pay around 19p per hour to park while they're at work, and also that over the period of 2019 to 2020, before COVID came into play and scrapped car parking charges altogether, there was a total of £90.1 million made in car parking fees from NHS staff. There is also some disparity in how the car parking fees are claimed, because the management is undertaken by private companies, so there's a lot of variation there. At BAPM, we do recognise this is an area beyond our control, and that we must remain aligned with other NHS workers, but it's something worth thinking about in terms of wellbeing. We asked the respondents, what do you have access to when you're on call? 53% answered that they had access to a bedroom of any sort, and for 63% this room was free of charge, and 50% had ensuite facilities as part of that. 26%, so just over a quarter, actually didn't have any access at all out of hours to a canteen, kitchen or vending machine, any sort of food preparation area. And when thinking about that, it's important to think about other associations. So the BMA Fatigue and Facilities Charter from 2018, which is often thought about as just being for doctors in training, but it is for all medical staff. And as part of that, they would advocate for access to food preparation area and access to hot food 24 hours a day, 365 days a year. So I think we can be in line with that. However, one of the in terms of when we started thinking and talking about access to a bedroom of any sort, I think we'll all agree that it is important, because, well, for a number of reasons, it would facilitate supervision of trainees, allowed you to rest on a busy on-call, remove the need to drive home, when you're exhausted, but how that would work in terms of those working non-resident and resident on-calls. At the moment, the BMA charter only covers resident on-call shifts, not non-resident. So that's something we'd be interested to hear your thoughts of in the Q&A later. Question 47 is relating to taking of annual leave. So you can see that there was some variation here, and just over 3/4 were able to take their annual leave always and often. The difficult thing was, of those, there's 12% who answered seldom or never. Unfortunately, we weren't able to determine whether that reflected difficulties with taking because of workload or personal choice in terms of how they felt about taking their annual leave. So, but we would obviously strongly recommend that all consultants take their full allocation of annual leave. Question 48 was related to burnout. So it was quite specifically asked, do you feel burnt out because of your work? You can see from the graph there that to a very high degree and to a high degree makes up a total proportion of about 24% of respondents stating that they feel burnt out to a very high or high degree. The biggest majority was in the somewhat group, with 40% of respondents answering that they felt burnt out to a somewhat degree, and then the remainder to a low, very low, or not at all degree was about 35%. We broke this down to look at it in a little bit more detail to see if there was any factors that we could see were linked with burnout, and whether there was any specific groups of people experiencing this more than others. And what we found, the most striking association was seen with the type of on-call that consultants were doing. So you can see on the graph to the left is a breakdown of on-call type as reported by those who felt burnt out to a high or very high degree. So overall, that was 24% of respondents. But you can see that amongst those who were doing purely resident on calls, they represented just under half, so 47%. So it was there was a bit more of an association noted within that group. And actually, but conversely, those who did not feel burnt out at all or to a low or very low degree, they made up the smallest proportion of the purely resident group. So the converse was true when we looked at it the other way around. There was also a slight association with age, although not quite as striking, in that the higher proportion of those over 50 years of age were experiencing burnout to a high or very high degree. So I think we all agree that's quite concerning numbers of neonatal consultants who feel burnout. Actually, we do know from literature search that was undertaken before any of this was commenced, that this is actually true across other specialties as well, and is comparable to that. In terms of the increased risk of burnout in those on a resident rota, we did wonder whether consideration should be given to ensuring that time on these resident rotas is limited with a clear plan to progress to a non-resident rota ultimately. Question 49 was actually fairly similar. Does your work frustrate you? And the spread of the data is actually very similar across question 48 and 49. And I think we'd all agree that those are quite inextricably linked. So it's not surprising really that those two data sets look fairly similar. Question 50, we asked the consultants who answered the survey to rate the key challenges in the career of a neonatal consultant from a list of 12 provided on a scale of 1 to 5, with 1 being not very challenging and 5 being very challenging. The top 3 most challenging areas were highlighted as balancing work and family, non-clinical administration, and the intensity of in-hours work. In terms of those that people felt were the least challenging areas, these were highlighted as the career progression, inadequate pay, and increasing litigation. We also gave the ability to do free text comments on this question, and you can see the sort of key themes that were identified relate to got capacity and transport issues, staffing issues, taxation, time for teaching, supervising, lack of funding for development of different services, and conflicts with trust management, particularly those in a clinical service lead position. Question 51. We asked the consultants whether do you enjoy your job as a neonatologist? As a trainee, I found it quite reassuring that 81% often or always enjoy their job. So that's good. And question 52 was related to future planning. So we asked about in the next 3 years, what you intend to do. I think one of the key points here actually is that 8% put multiple answers, which I think suggests some degree of uncertainty, but 50% will continue working as they are now, and 17% are considering stopping in one form or another. And the majority of these were, as you would expect, in those over 55 years. But there was also slightly more burnout and frustration amongst this group, but the numbers were very small. The others were either going to slightly increase or slightly decrease their how much they were working. One thing that we did discuss in amongst this was the implications of the potential tax burden and pensions, but unfortunately the questionnaire wasn't set up to assess that implication, so we can't really take much information from that. Of those who plan to retire and return, we asked what that would be too, in terms of what their ongoing plans would be. And actually, despite only 10 people saying that they were going to retire and return in the previous question, 29 people answered this question. So I'm not sure whether that underestimated for the previous question or overestimated for this one. But nearly 2/3 plan to return to clinical work, which from a workforce point of view is reassuring. Question 54, we asked people whether they would recommend neonatology as a career. And again, this is similar to the question previously, in that about 83% would recommend neonatology as a career. We did also ask if, for those who answered no and yes, some comments on that area. And of those who answered no, the common themes were actually very, very similar to those which were highlighted as key challenges on one of the previous questions, in the lack of work-life balance, high intensity work, too much administrative work, and emotionally challenging work as well. But of those who answered yes, they felt their job was rewarding, fulfilling, with great teamwork and a huge variety. The last question on the survey was about if BAPM was to provide more resources or support when starting out as a consultant, where we should be targeting this. And again, there were lots of suggested areas that were put to the respondents, and the highest priority areas were identified as job planning advice, mentorship and peer support, and then rota design. But the lowest priority was given to career progression, and that was especially for those who were starting out in their career, and 21% wellbeing and work-life balance. They were also given the opportunity to provide other examples of resources that they felt might be useful. And that you can see those here, that they're structuring job plans with increasing age and illness, pensions and pay, best ways and support the juniors, maintenance of skills, recommendations for consultant working, governance and processes, media support, and neonatal research. And over to Helen now for the Q&A. Thank you.
Anna, thank you very much indeed. That was great. And thank you to all of the speakers. And a big thank you to Wendy for overseeing this work, and really to everybody for the huge amount of work that's gone into analysing the responses and producing the slides today. So what I'm going to do, you now have a choice, delegates, because there's relatively small number of people on this call. We would be delighted if anyone would like to put their hand up, switch their camera on or not, and speak to the group as a whole. That would be great. And if any hands go up that I haven't spotted, perhaps Kate will prompt me. In the meantime, I'm just going to go through the comments received so far in order. And the first one that came in was from Dr. Aaron Ramachandra, and I'm going to direct this to Wendy. Dr. Ramachandra's question was, are non-resident or hybrid on-call cover arrangements for the weekends split or running over 72 hours? I don't know that we specified this. And also a very interesting thought, what would be a safe period of continuous cover in a NICU? Wendy.
Yes, very good question. And I know that I don't think we specified, looking at the questions, the length of time over a weekend when we asked the direct questions about the weekend on call. But I know we did consider about that length of time, because we put in a specific question, didn't we, Helen, about whether there was a backup consultant for people that were doing extended times, either over a long bank holiday or a long weekend. And I think it was in Ajit's presentation, and there's a very low response rate saying that they did have a formal backup arrangements, and that most people start their long weekends or a double bank holiday at the beginning and finish at the end with no formal backup service, and presumably rely on goodwill if they're very tired or they need a second opinion. It'd be interesting to know what the membership that are on think.
Yeah, Sajid, you had a comment there too.
Yeah, just to add on to what Wendy was mentioning, I think when you look at with the split hours that people mentioned about how they worked, it varied from being 4 hours. It was very variable from 4 hours all the way up to 14 hours per day over the weekend. Now, I think there were 1 or 2 respondents who did say that their weekend on-call was in such a way that they started on Friday 5 p.m. and ended on Monday 9 a.m. But they were on site till around 2 o'clock on each of the weekend days, but then they were available as and when required. So but I think that was sort of very long ago. I remember when I was starting as a trainee, but I don't think that's a usual practice. But because we've now gone into hybrid system, it looks like the responses were that they were splitting the weekends, but varying from 4 to 14 hours.
Yeah, I think the problem, if I might chip in there, Sajid, as well, is that for people with relatively small numbers of people on the rota, there is a balance to be struck, because if you split all your weekends, you end up doing twice as many weekends, and that may have a greater impact on your quality of life than doing fewer, more intense weekends. I think just to highlight to everybody on the chat, we would very much appreciate feedback from this. I think we'll maybe need to look into how we best achieve that, because the idea of this survey primarily was to gauge what people were actually doing and what people thought BAPM could do to help, and where we, there's no piece of data that says a weekend shift should be 10 hours, 12 hours, 4 hours. That's not written anywhere. So we're trying to kind of achieve consensus, and from that we really do need membership feedback. So very much an encouragement for people to let us know what you think. The next question I'm going to bring up is from Joanna Webb from Swansea. And Joanna, you've said you're interested in how other units calculate PAs allocated for on-call duties, particularly for non-resident and consultant delivered transport services. Vimal, you looked at PAs and SPAs. Do you want to comment on that, or perhaps how we might get information in from our members as well?
Yeah, I mean, I'd be interested in the kind of response of other group members as well. We didn't specifically ask that question in terms of how PAs for on-call duties were allocated, or for non-resident or consultants delivered transport services. I think it's a valid point, and whether it's something that we can provide some guidance on in recommendations would be worthy of consideration. It won't be evidence-based. I think we'll just have to establish a consensus, but I don't know if anyone else has got any thoughts. The nature of the survey was that it could only be so granular in terms of the questions. Otherwise, the length of the survey was going to exponentially increase. So I'm sorry, I don't think that I can reliably answer that question.
I've actually got a hand up. Thank you from Joanna Berson. Do you want to put your camera on and come in? Thank you.
Yeah, thanks.
Great to see you. Great to see you.
Hi.
Thank you for joining. Yep.
So I'm Jo Berson. I'm the head of service for Leicester. So it's good work that you've put forward today. That's really helpful. But I'm just wondering whether there's any way of pulling that together and giving some recommendations as to what the optimal arrangements might be to facilitate with future workforce and rota designs.
Wendy.
I was just writing down what she was saying, actually. So, Joanna, thanks for that comment. I mean, the idea that the results of the survey and the questions that you ask and the comments that we get in the chat is that they will feed into a recommendations report. As far as possible, obviously, the recommendations will be to support and align other recommendations that are already in existence, but there may well be some that are out with current national guidance. I mean, one good example is the question about PMRTs and how we're going. You know, what do the BAPM members want from that? Do you want it to be DCC? Do you want it to be SPA? The time, you know, it seems like the vast majority of you don't have any pay for contributing to such an essential service to improve care. So that's really what we're about today. We'll be publishing the results of the survey, but we really want to produce some recommendations, and there will be gaps where we can't align with national guidance because it does not exist currently, but we'll be seeking advice from the BAPM membership as to what they would like to see in the report. So today, really, we're hoping to have an opportunity for you to be able to share your opinions.
Thanks, Wendy. And just to emphasise to the audience, your opinions really do count. I mean, but a lot of BAPM recommendations, we've just reviewed our service standards, our quality standards. Everything is really based on consensus. In a lot of places, there's really very little evidence. And what we want is people to agree that recommendations are reasonable. And I think it's helpful to maybe solidify your opinion on that when you know what's happening across the piece. I've got another hand up here. Heike Rabi, sorry if I've mispronounced that. Would you like to put your camera on?
That's fine. Hello.
Hi there.
Hello. I'm Heike Rabi from Brighton. I just want to emphasize a bit what one of the speakers said, I can't remember what it was, that additional duties should also be really educated in the job plan. We have quite a lot of requests to attend PMRT meetings. And as you said, they really need to be prepared properly. And there's so many requests coming up to us on top of the heavy clinical workload when you are on clinical duties. And I think this really needs to be taken into account, because we are meant to do all these things, but you know, when do you do it? When you have babies on the unit, no junior doctors to look after them whilst you're doing this other thing. So I think that these kind of things should be I would put into the recommendation as well.
Yeah, thank you. And that aligns with Geraint Lee's comment to say sometimes, and not just in his organisation, there's a misalignment between job planning, how things actually work out, how different people work within the roles and job planning. And Geraint's other point was I think again for Wendy probably, but anyone in the team wants to chip in. When we received more than one answer from the same unit, were you able to ascertain the level of agreement within these teams? So does everybody in the same neonatal unit think they're on the same rota? Not sure if we had granularity in that, but maybe somebody. Wendy?
We knew the neonatal network, but it is an anonymous survey. So we don't know people's names. Marcus may have some more information, but I'm pretty certain it was down to network level. I don't think we had individual trusts, but we can come back to you, Geraint. I will look while Helen's moving on with the next question, because I can look that up straight away.
Okay, so I don't see any more hands up at the moment. Sankara Naranya, I was saying it would be really interesting to link workforce models in LNUs to activity and patient outcomes. I mean, there are some data linking nurse staffing with patient outcomes, but I don't know of any for medical staffing. And just to comment, you know, there's unwanted variation from NNAP and regional dashboards, and we just don't have a clear link to workforce data. Would anybody like to comment? Oh, in fact, Gerard's got his hand up. Gerard, would you like to come in there?
Sorry, thanks, Helen. It was just going back to applying rules and how we generally what recommendations we could give. And Grenville has made a really good point in the chat about generalizations and a lack of evidence. And the challenge is that consultants, we're sometimes, and healthcare professionals as a whole, we're sometimes our own worst enemy. And so in order to have time off, in order to create holidays, in order to do different things, we will put ourselves through lots, including working hour after hour, working whole weekends so that we can have time off the following weekend or whatever it may be. So it would be quite easy for BAPM to say, in the same way as the European Working Time Directive did, that you shouldn't do 4 13-hour shifts in a row, and still be on call in between any of those things. But as Grenville said, for units where there is less intensity, so being on call for 13 hours doesn't necessarily mean being in the building for 13 hours or being on your feet for 13 hours, even in NICU and LNU or a SCU. And so it's just difficult to make such generalizations. I don't think that somebody should be awake for 24 hours and work the following day. That's quite a simple recommendation, but it's a lot more complex than that, dependent upon our activity.
Yeah, I think you make a good point, and it's also about certainly as the mother of some trainee doctors at the moment, if the rotas become too tight and too prescriptive, you then have an enormous impact on quality of life and ability to take holidays and go to your brother's wedding and all that stuff, which also has an adverse impact on quality of life. So it's about trying to find a sensible way down the middle, which is why I think BAPM needs to do what it's very good at doing, and that's getting consensus from our members.
We have to start. Of course, we have to take care of ourselves,
yeah,
and our well-being, but we also have to start with the safety of our patient. And we may say that we can work for 24 hours without sleeping, but that's not necessarily good for our patients. And it's how we find that balance in what is safe for the families that we take care of and what is safe for ourselves and our own families.
Yeah, thank you, Gert. That's points very well made. I think it's just been suggested by Richard Nicol that there is a new ruling that trusts must provide hot food 24/7. But obviously that's not happening everywhere. And also I note that maybe we've got too many type A people who turn out to be consultant neonatologists. I think we'll maybe not go into that one today. A comment from Karen Turnock: it's a bit of a challenge to keep track of the numbers. If on a resident rota to progress to a non-resident, does that mean that both already exist in one place? Sajid, I think, yes, we did have resident and non-resident rotas in the same place. Would you like to comment on that?
No, I think when the data generally showed that there was more of a hybrid working pattern. If that answers the question as an overview, but is that what the question?
Well, certainly from my interpretation of the data, it's remarkably difficult to make these questionnaires up, actually. that's one of the learning points we try and do. One is that lots of people are working rotas, for example, a weekend day where you are expected to be in the building for part of the day, and then you would be on call maybe in the evening, and we called that a hybrid on call. But I think pretty sure there are units. Oh, Karen's got her hand up there. There are, so we'll just bring in a minute to clarify that. Thanks, Karen. But there are units where some consultants are on the resident rota and some consultants are not. But Karen, maybe you'd like to elaborate further on your question. Sorry if I've picked it up wrong.
It is so hard to do this kind of questionnaire, isn't it? There's just so much variability and variation. But as a place that we're looking at whether we should, as a consultant body, be resident and more quickly available 24 hours a day, 7 days a week, that sort of concept of to prevent burnout, there were some numbers, I think it was in the last section, about moving on from being resident on call to being non-resident on call implies that you should have both, or you would need to have both in one place to be able to do that. And I'm not quite sure if that's a model that places are working with, because I thought people were who tried to put in sort of a resident on-call consultant tier and a consultant on-call tier were really struggling with that as a model, and whether that was represented in these numbers or whether that people are, I just don't, I don't know how we should be working in a busy unit to provide that sort of immediacy of availability of consultants without consultants being the tier 2 people. Does that make sense?
It does indeed, Karen. Does anyone want to come in from the audience who perhaps works in a department where there is a combination of resident rotas? I know there's been a lot of discussion about that then creating less of a team, perhaps, where consultant bodies seem to be at 2 levels, if you like, and that's felt to be a negative thing. Heike, again, thank you. You've put your hand up there. Sussex.
Yeah, we recruited several of these people, such colleagues, who, as we were short of middle grade doctors, so it was clearly written in the job advert. But so far, we always have made an effort, as now, some of us start to retire, that those colleagues could come off the hybrid resident on call to go into the sort of more traditional on call system. We still have some hybrid. I mean, people do still work sort of resident shifts simply because we don't have the junior doctors. So in the moment, I mean, not me, because I'm sort of in the elderly population now. I mean, I sometimes do as well, but only if there's nobody else. But we do have people now more and more actually stepping in to do junior and middle grade rota slots, because we cover 2 units and people go off sick all the time in the moment with COVID and other related things, and it's a shortage. So you may have plans, try to get them off, but in reality, as actually that it's creeping more and more in that everybody does resident shifts.
I think it's also important, though, or else this will have no boundaries, that we distinguish between what are consultant duties and what are middle grade duties. And a consultant covering a middle grade is not a consultant job. So I think we need to be, obviously it's an emergency that happens regularly, it needs to be done, but we need to recognise that should be an exceptional circumstance. But I think that's a whole other,
it's not really
other webinar. I've got Fiona has a hand up. Fiona Wood. Fiona, hello.
Hi there. Hi. So I work on a resident consultant rota. So I was just going to respond.
Great to hear from you. Thank you.
So you're
looking good on it.
In our centre, we've got a resident tier of consultants. There's 7 of us contribute to that, and then there's all the other consultants are on an on-call non-resident, and it's to do with the makeup of our service. And I think that is important when you're thinking about the comments that Geraint made, that it's difficult to do sweeping set rules for an entire nation when every service is very different. So we've got a split site, we've got a surgical, medical, ICU, and then we've got a special care on a different site that's a drive away. So a lot of that's about managing the risk of a split site service. All of us are working, like the resident tier is working as consultants. We've got a full complement of juniors that we're working alongside. But in a busy centre, there's plenty of work to be done for a consultant overnight. So I think it is very much about the centre that you're in, what's going to be required. And I think that's quite important. I think one of the other things I wanted to maybe bring up while I've got the opportunity with my camera on is thinking about the future generations who are following us into this specialty and how their working arrangements have been influenced by the junior doctor contracts and what their expectations of work life may be and how different they are to perhaps what we're doing now. And when we're thinking about any of these workforce plans, how do we make this an attractive career that people are going to want to do? Anyway, that's my bit.
I think, and leading back, some of the earlier comments was that old age-old nugget about when you're too old to do on-call or too old to see the veins, maybe. That's a very, very difficult question, and I think that's something else that BAPM would really welcome feedback from our members. I remember as I approached even olderhood, it was suggested by a younger colleague that in order to come off the on-call, one should go to occupational health. And I'm not too sure that I think that's an appropriate solution. I think there needs to be something that's equitable across the board. I may be a minority opinion in that. So Wendy, you had your hand up, and then Richard Nicholl, thank you after that. Wendy.
Oh yeah, I was just really great points have just been made by the last speaker that came online. I just wanted to say about the first point. I think I wouldn't want anybody on the call to worry that, you know, any recommendations report is going to have sweeping generalisations that, you know, that we expect all neonatal units to adhere to. I wouldn't want people to worry about that. What we're trying to explore is what's happening at the moment and examples of challenges and also examples of good practice. And we'd all be really grateful, actually, if people would be willing to share some of those. You can either put them in the chats, you can tell us, or you can email the BAPM office. Marcus and Kate and Laura are very willing to hear your examples, so because we're looking to be able to put those within the recommendations report. So for some units where they might be struggling, for example, with a certain structure or pattern of working, they can actually have an example of good practice from somewhere else in the UK where there's been some solutions found. So it's not about one size fits all. I just wanted to reassure people. But then over to Anna and the trainees to answer the question about the future. Thank you.
Yeah, Anna, what do you think about stopping doing on-call? How old would you like to be when you're not doing on-call?
Next year, no, too soon.
And also we have to put this in the face of a whole changing societal structure and a deferment of pension age. So it is quite a difficult one. So we would certainly recommend feedback. Richard, you've had your hand up, and then I've got some comments from Grenville after that.
Yeah, I did night work for 39 years. So I feel I've put a shift in, and I managed to come off the road at the start of this year. I got the sense that the only way I could come off the road was either by making a dreadful mistake or getting a dreadful illness, and I don't really want to do either.
Yeah.
So I did what I usually do in these situations, and I did a literature search. And I'm sorry, folks, we're all paediatricians, we're far too soft. We're not bullish enough when it comes to hard decisions. I searched what every single Royal College says, surgeons, anaesthetists, you name it. I also looked at what all the various trusts say, and the trusts, of course, talk the talk, but they don't walk the walk. They talk a lot about we want to retain you. I know a colleague who was very high up in the college, Helen, you will know his name. He requested from his hospital to do a retirement return. They turned around and said, no, thank you. So he's very happy living in Portugal, and two fingers to the rest of the world. But so you've got to be careful, because it's easy. They'll agree for you to retire, but getting the agreement to return is the tricky bit. So you've got to know your colleagues. But the College of Paediatrics says that no parent in the middle of the night would want their child to be seen by someone over the age of 60. That's our college. So you can just think about that. That's what our college says. But of course, legally, you can't mandate that people must do things, because you run into all sorts of ageist rules. But what I would say to you guys in your 40s and 50s, it's amazing. In 10 or 20 years' time, you will be 60. You will. And I worry about colleagues who are all in the same cohort. If you're all 40, well, surprise, surprise, in 20 years' time, you'll all be 60. So I've written in the chat, if we were starting from scratch, I would have much fewer but bigger units, because we were always, I think it was one of the PICUs in Manchester that was always held up, that because they were such a big unit of 30 consultants, they could do this sort of transition. It's very hard to do that when there's only 6 of you.
Yeah.
So, you know, that's the practical thing. So it's a bit of a fantasy, but I think we need, you know, fewer, bigger units, so that as you progress, perhaps you step down and you go downstairs and look after the LNU, and you leave the NICU stuff to your younger colleagues. But, you know, I trained in that era where we didn't know the dose for nitric oxide. I've done all that stuff. I don't miss it.
Yeah.
So you've got to just be realistic, I think, about your future planning.
Thanks, Richard. I think a lot of it boils down to being good to yourself as well, and maybe all us type A personalities are not so good at that. And Grenville, you also make a very good point here about the large elephant in the room with regard to distance or time from site if you're non-resident. That's something that I don't think is mandated anywhere. And again, it's something that's maybe something that BAPM could have a consensus recommendation on. I think it's probably about return time, but what is a reasonable return time to a NICU? And Helen Chitty has commented that parents maybe don't want elderly consultants. It was terrible when 62 is elderly, she said, if the cap fits. You don't want the children to be seen by someone who's been awake and at work for 24 hours either. Shuling appeared on the screen. Did you want to say something? And then you disappeared, sorry. Oh, here you come. Did you have a comment? No? Just playing with the camera. Oh, no, coming again. No. Are there any other comments that anyone would like to make? There's also a comment from Giles Richardson about the changing skills of your middle grade doctors. So your middle grade doctors might, well, we're all familiar with that, might be peri-consultant and actually in need of an opportunity to fly overnight, or they might be ST3, ST4 who have never intubated a baby before. So that's obviously makes a big difference to your on-call.
You've got Ngosi's hand up, Helen.
Oh, sorry, Ngozi, thank you. In you come.
Thank you. I was a bit late, so I'm not sure how much of what I'm going to say has already been covered, but I thought I'd just say it anyway. And it was really about the comments. Richard, I was surprised to hear that they're saying that if you're above 60, you shouldn't do any on-call. That's news to me, but it's interesting. However, as you know, we did a neonatal critical care review, which recommended the minimum the source of the number of days of intensive care units should be doing, and maybe this is one of the answers to this, in having larger units or with collaborations with other LNUs so that you can cross cover. It also came out in the Ockenden review about cross covering and working together with other organisations, and so maybe that's one of the things that we should be looking at. We've been really lucky in Manchester because we've now got one of these mega trusts where we have 3 neonatal units in one, and perhaps one of the things that we could look at is doing more sort of leadership roles as you get older and covering the LNU and recruiting newer consultants. The problem you may have when you have a really large group of consultants, and I know my colleagues are here and have covered this, when you say that people step off the rota, I think in our unit we must have a glut of about 10 people who are with a 5-year span of each other in terms of age. So if they all come off the rota together, that will leave us in a very tricky situation. So it's easy to make some of these recommendations, but sometimes in practicality you just cannot implement them. And the last thing I was going to say is that, as you know, there's been money being provided for additional medical support from the Ockenden money. And so there is a real need to be able to evidence that as much as we can with areas of good practice, so you can get this funding for units. So that's what I was going to say. There will be this NHS England are going to organise a workshop as well for medical staffing and nurse staffing to see how we can use it a bit better. And I know Wendy went to the first one. There's another one coming in March. So if people are interested and want to contribute, I will send out the dates to BAPM via Larry and Wendy.
Thanks, Ngozi, very helpful. And you'd also commented earlier, and again, something that might really be for BAPM, is to come up with a list of obligatory things to have for every consultant to have SPAs for, which would include PMRT. So that, I think that's for me, one of the really striking points of the survey is that we are demanding PMRT, and rightly so, but we're actually not resourcing it. And it's not going to get better until we properly resource PMRT.
That would be really helpful, Helen, because from a individual point of view, when you go to your organisation, you say, BAPM said, this is what we need in our job plans, you can evidence it. That's really powerful. So for people struggling with time in their job plans, it would be really good if we had a list of things that this is what the professional society says we must include.
Yeah. Peter McEwen. I see you've got your hand up.
Yes.
Love to
Sorry,
see you.
no,
Hello,
no,
come in.
hi there. Sorry, no camera here in Poole, so you can't see me, but this is
Oh,
just a
what a
quick
shame.
question. We're just employing other consultants. Now, in terms of sort of succession planning for the role, do you think it's possible for me to go to the trust and say, right, there are certain of us who are approaching our 55th birthday now who want to do less on calls. There are 2 new consultants. We want them to do more on calls, but obviously, if we're going to sell that to them as the package, we'd have to be able to say to them, and when you reach 55, the same thing will happen to you. But can you do that? Does anybody know? Can you approach your trust and say, I want to make a plan for something that's actually going to happen in 2042? Or would they just laugh at you and say, no, you can't do that?
I don't know the answer to that one. I'm not sure if anybody does, but would anybody like to come in and discuss that with Peter? I guess my concern would be, so we're talking 25 years. I mean, 25 years ago, the retirement age was 65 and now it's 67. So one assumes that in another 25 years time, they might have pushed retirement further back. I don't know. Has anybody got experience of negotiating reduced hours, and is it fair? I think the thing that I have often heard said is it appropriate that a bunch of consultants on a rota could be doing differing things to the rota?
I think, Helen, I was just going to say that the survey comments that came back didn't give that level of detail, unfortunately, to answer Peter's question. But it's really important, isn't it, that we don't just keep doing quick fixes and employing people for something that works for the next 5 years and they end up in the same rota for 20, 30 years. But how we address that is really complicated.
Yeah, so we are running out of time, but in the meantime, we've had 2 more comments. We're going to take 2 more and then the rest will, remember, BAPM is open. We really want feedback from our members. Prakesh, you had your hand up first and then Richard Nicholl. And we probably have to draw to a close.
Hi, Prakesh Tyagarajan from Isle of Man.
Where are you from, sorry? I was talking over you very rudely. Okay, come in, thank you.
Just to answer Pete McEwen's question, yes, the new consultant contract, which is now 20 years old, does give you provision for that, but it has to be discussed well in advance during job planning. In fact, many of the job plan process pre-formatted forms include retirement plan heading. On that, I mean, when I was CD, a couple of my obstetric colleagues opted to do that with 1 year's notice, and we allowed that coming completely off the on-call. One of them wanted to just come off the obstetric on-call, but stay on the gynae on-call, and the other one wanted to come off all on-call, and we could facilitate that, but heavily dependent upon the goodwill of other colleagues on the same rota. So it is possible, harder in smaller places.
But did you say 1 year's notice as opposed to 25 years notice, which seems quite generous?
We were able to manage this with 1 year's notice.
Thanks. Richard.
Well, the Isle of Man sound very organised because that's sort of team job planning, which the college recommends. It rarely happens. I'm happy to email the arguments that I put forward in relation to age and coming off the rota if anybody wants them. Peter, I think I can get your email if that is helpful.
Yeah, Richard, do send me the information if that's okay. It's Wednesday.
I will do, yeah.
Yeah, that'd be brilliant, and we can make sure that we've got it in the.
Then you can disseminate it or something, yeah.
Yeah, Anna did a literature search at the beginning before we designed the survey, and we can just cross-check to make sure we've got all the references that you've got. Also, that would be great.
Okay, fine.
Thank you.
Thank you. So, very reluctantly, I think I'm going to have to bring this very fruitful discussion. There is some other comment in the chat about obstetricians are, I was going to say, better at job planning than neonatologists. Of course they're not, but there's often more of them on the rota, I think, which makes it easier. Certainly in our place that was the case. So regrettably, we're going to have to bring this very interesting discussion to a close. I would just like to thank everybody on the call. Thank you all for joining in so enthusiastically. And most thanks to everybody who has contributed to analysing the data and today's presentations. And I'll just maybe give the last word to Wendy as our chief.
Okay. Thank you very much. I think the last word is just to say thank you to everybody, and really please do send in either your concerns or examples of good practice to through the BAPM office. You can contact me directly if you want to, wtyler@nhs.net. Really wanting to get this right for BAPM members. And not publish something that you all think that you don't like at all. So it needs to be something that you need and is valuable to you. I just wanted to say, if you're not a BAPM member, then please can you join? I know I'm not the treasurer anymore, but it's still my role as a lasting treasurer job to make sure that you sign up for BAPM membership if you can, because only together can we make a difference. And I just wanted to pick up on one thing that that came through strongly for me in Anna's slides when she was saying the people that actually enjoyed their job. They mentioned their teams, and I think if we all work together as a team, we're much more likely to be able to solve all these really very difficult problems. But that can be difficult at times. And
yeah, but we've got a toolkit and how to do that.
we have, and that's what I was going to show. I was going to try and fly, but I don't need to because Helen's there for me. She's my main girl. All right. Okay. Thank you very much, and have a good afternoon. Thank you.
Thanks,
Bye.
everybody. Bye.